Salam and a very good day to Dr. Nur Nasha. Today, our group will be presenting about the use of radioactive substance for treatment and pain palliation. I am Peerbux Warda, and together with me are Aina Nabilah, Muhammad Firdaus, Nur Nasha, and Wan Suhaiza. Our topic is divided into 5 different subtopics, which include radionuclides' properties and characteristics, protocols and procedures, patient dose and dose administration, radiation monitoring and safety, and waste management. I will present the first part, which is radionuclides' properties and characteristics. A radionuclide is an unstable form of a chemical element that releases radiation as it breaks down and becomes more stable. There is some evidence that radioisotopes may give pain relief over 1 to 6 months. For patients with cancer that has spread to their bones, a single dose of radiation therapy may treat bone pain as effectively as a series of lower doses of radiation delivered over multiple days, according to the results of a clinical trial. Radioisotopes are of 2 types, naturally occurring and man-made. Natural isotopes are either stable isotopes or radioactive isotopes that have a sufficiently long half-life to allow them to exist in substantial concentrations in the Earth. However, separating and extracting these types of radionuclides for scientific or medical utilization is not a cost-operational solution. A synthetic radioisotope is a radionuclide that is not formed in nature. No natural process or mechanism exists which produces it, or it is so unstable that it decays away in a very short period of time. Manufactured radionuclides are a far more efficient approach for scientific usage. The 3 main properties of radionuclides are half-life, emission type, and activity. Physical half-life of an element is defined as the period of time required to reduce the radioactivity level of a source to exactly 1/2 its original value due solely to radioactive decay. The range of half-lives is boundless and is unaffected by anything that we humans can do to the isotope. High or low pressure or high or low temperature has no effect on the decay rate of a radioisotope. Decay occurs through 3 processes: alpha decay, beta decay, and gamma decay. Alpha decay occurs when an atomic nucleus emits an alpha particle, the helium nucleus, and thereby transforms or decays into a different atomic nucleus with a mass number that is reduced by 4 and an atomic number that is reduced by 2. Beta decay is divided into 2 types, positron emission and beta minus decay. In positron emission, also called positive beta decay, a proton in the parent nucleus decays into a neutron that remains in the daughter nucleus, and the nucleus emits a neutrino and a positron, which is a positive particle like an ordinary electron in mass but of opposite charge. Whereas in beta minus decay, an energetic negative electron is emitted, producing a daughter nucleus of 1 higher atomic number and the same mass number. Gamma decay is a type of radioactivity in which some unstable atomic nuclei dissipate excess energy by a spontaneous electromagnetic process. In the most common form of gamma decay, known as gamma emission, gamma rays, also known as photons, or packets of electromagnetic energy of extremely short wavelength, are radiated. Activity in radioactive decay processes is the number of disintegrations per second or the number of unstable atomic nuclei that decay per second in a given sample. It has the SI unit of Becquerel and is inversely proportional to the half-life of an element. In this table, all the radioactive elements used for treatment are included together with their mode of decay, half-life, and amount of energy. It can be observed that the nuclides having the same decay mode are usually grouped to be used for the same application. Moreover, the nuclides having the longest half-lives are usually used for radiotherapy. I will now leave the floor to Nasha for her to explain the next part, which is about the protocols.
Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Nasha binti Razali. I will be presenting about protocol and procedures in handling radioactive substances for treatment and pain palliation. First of all, we need to make sure the identification of patients is correct. Identify the concerns of the patient and the treatment required correctly. Since the treatment requires radioactive substances, we have to avoid any mismanagement or mistreatment to the patient. The selection of radiological equipment is appropriate. This is to ensure the safety is improved, to support and comfort the patient, and also to protect the skin of the patients. Some of the appropriate radiological equipment are by using adaptive equipment and also assistive technology devices such as special wheelchairs and seating, mechanical lift and lift sling, and also the special bed cushions or mattresses. Next procedure is the exposure of patients is optimized. All the patients' dose and calculations are calculated way before the treatment in order to patient receive the ideal dose for treatment, so that the dose that will be given is not too much or not too little, so that it become effective to treat the pain palliation. Moreover, we have to avoid any unnecessary additional examinations. This is to conserve patients' energy as much as possible, because patients might become weak after the treatment and we need to conserve the energy. We have to eliminate unnecessary bending, reaching, or walking. Other than that, appropriate image storage techniques are in place. This is to ensure systematic and convenient techniques of image storage, so it is easy to trace and does not disrupt the quality of the image. Moreover, exposure of women who are pregnant or likely to be pregnant are justified, since pregnant women are included in high-risk patients. This is due to the sensitive developing embryo that have many cells are dividing at very fast rate, so they needed extra precautionary steps. Next, shielding of radiosensitive organs is provided as appropriate. Radiosensitive organs are organs that are very radiosensitive to and most likely to receive harmful effect from ionizing radiations. Some of radiosensitive organs are such as gonads, lens of eyes, and thyroid. These part of organs needed extra care and appropriate shielding from radioactive substances. Also, patient cooperation should be achieved to produce a diagnostic quality image. Patient need to be positioned correctly and limit any movement during the treatment. This is to prevent any motion artifact detected in the image that will be obtained from the treatment. For the next procedure, we need to provide written protocols that specify the operational parameters to be used for common diagnostic radiological procedures. Make sure the operational parameters used for the treatment are correct and precise, such as how much the KVP and MAS are used, and also how long the time of exposure for the patients. Last but not least, the site-specific written protocol should be developed for children. Children has increasing mitotic activity for growth, meaning they have a lot of cells that are keep dividing compared to the adults. They are 2 or 3 more times more susceptible to the radiations. Radio sensitivity level of neonates are the highest compared to the children. However, children has higher radio sensitivity level compared to adolescents, which indicates adolescents has the lowest radio sensitivity level in the category of children.
Okay, now I will continue to the next point, which is patient dose and dose administration. Patient dose can be determined by person weight in kilograms, but some doses are determined based on body surface area, which are calculated using height and weight. Even once body surface area is taken into consideration, doses for children and adults differ because children's body process medication differently. Children may be quite sensitive to medication. Next, doses of some treatment may also be adjusted for people who are elderly, have poor nutrition, obese, taken other medicines, currently getting radiation therapy, have low blood cell counts, have liver or kidney disease, and may otherwise be unable to tolerate full doses. Dose administration. In therapeutic nuclear medicine, therapeutic activities of radiopharmaceuticals are administered. These radiopharmaceuticals are usually labeled with beta-emitting radionuclides, more recently also with alpha emitters. The example for treatment that use radionuclide is thyroid therapy and paliation of bone pain. Benign thyroid disease, hyperthyroidism or thyrotoxicosis, most commonly caused by Graves' disease, which is autoimmune disease causing the thyroid gland to swell. Thyroid toxic nodules are responsible for overactive thyroid glands. Iodine 131 radioiodine has been used effectively as a therapy for hyperthyroidism since 1940s and widely accepted. There are fixed activities and personalized activities that we use in thyroid therapy. In fixed activities, for ablation, we use around 1,100 to 4,500 megabecquerels, and for subsequent therapy, up to 9,000 megabecquerels. Absorbed doses to remnant tissue, residual disease, normal organ that can be varied by several orders of magnitude. For the personalized activities, first, the idea of delivering a 2-gray absorbed dose to the blood and limiting absorption levels at 48 hours. Afterwards, approaches based on whole body absorbed doses as substitute for red marrow absorbed doses. Then, as we can see, the first picture shows 180 megabecquerels absorbed dose of radioiodine from a tracer administration. Then, the second picture shows 8,193 megabecquerels absorbed dose of radioiodine used for therapy. And then we continue to palliation of bone pain. Radiopharmaceuticals have been proven to be effective treatment for bone pain for almost 70 years, and strontium-89 is first used in 1942. This is the list of wide range of radiopharmaceuticals that have been used in radionuclide therapy. administered activities. Standardization for strontium-89 and samarium-153 is usually done according to the manufacturer's specifications. For other agents, vary widely according to local protocols. Retreatments are typically thought to be helpful as long as the hematological toxicity has resolved, although no study have been conducted to determine the appropriate time or doses of administration. The EANM and IAEA has provided recommendations regarding retreatment scheduling. Radionuclide is widely used in terms of beta emissions and physical half-life. For beta emissions, there is longer range and shorter range of beta emitters. For shorter range beta emitters, rationale to target all the disease. Shorter range beta emitters and also alpha emitters, rationale to avoid unnecessary toxicity. For physical half-life, there is some indication that the longer life strontium-89 might cause a reaction that takes longer to initiate but lasts longer.
Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Firdaus bin Azman. I will explain about the radiation monitoring and safety in medical radiation exposure. Other than we practicing ALARA, which is as low as reasonable achievable, and STD, shielding time distance, we also have two radiation protection principle if we considering for the radiotherapy. The first one is justification and the second one is optimization. In medical exposure, the persons, primarily patients, are deliberately, directly and knowingly exposed to radiation for their benefits. Important to remember that in medical exposures, applying a dose limit is inappropriate as it may limit the benefit for the patient for the treatment. Consequently, only two of the radiation protection principles apply, which is justification and optimization. Justification plays the role of gatekeeper, as it will determine whether the exposure will take place or not. If it is to take place, the radiological procedure should be performed in such a way that the radiation protection and safety is optimized. In a treatment, we basically account for the benefits and risks. The diagnostic or therapeutic benefits produced by exposures are weighed against the radiation detriment they might cause. If the risk is higher than the benefits, so we might consider for the other available techniques that do not involve the medical exposures. There are several requirements that has been highlighted by the IAEA safety standards in medical exposure. Requirement 37, which is the justification of medical exposures towards the relevant parties, shall ensure that medical exposures are justified. There are three levels in this requirement, which is level 1, general justification of the use of ionizing radiation in medicine. This general justification of medical exposure at the first and most general level, it is accepted that the proper use of radiation in medicine does more good than harm to the society. And the level 2, justification for a generic clinical condition. Generic justification of a given radiological procedure should be carried out by the health authority in conjunction with appropriate professional bodies. Possibility of accidental or unintended exposure should be considered. This applies to new technologies and techniques as they evolve. Next is level 3, which is the justification of radiological procedure for an individual patient. This justification is to specific objective of the exposures, the clinical circumstances and the characteristics of the individual involved should be taken into account. National or international referral guidelines developed by professional bodies together with health authorities should be used. This includes the details of the proposed and alternative procedures, the characteristic of the individual patient, and the expected dose to the patient, and the availability of information on previous or expected examination or treatment. As I have mentioned, there are particular groups of patients for the justification on medical exposure, which is the first one is pregnant woman, and the second breastfeeding, and the third is pediatric. For the pregnant woman, we know that fetus is actively in cell division, so it is said to be high radiosensitivity. For the women who are breastfeeding, we must concern about the radionuclide transfer to the babies. And for the pediatric, it still considered as actively in cell development, so we must consider if the treatment will trigger for the development of cancer cell. In conjunction, the risk of incurring radiation-induced stochastic effects. There are triple S approaches to justification to ensure effective justification of medical exposure in diagnostic imaging in the day-to-day practice. The first A is awareness. The awareness is to enable effective communication about radiation risk. And the second is appropriateness, to ensure that those referred for radiological examination really need them. And the third is audit, to check the effectiveness of the referral process and related processes priority to justification. This audit is to detect the problem and improve for the patient care. For the awareness is we increase the awareness in public. Next, we go to the second principle, which is optimization. Requirement 38, optimization of protection and safety. Registrants and licensees and radiological medical practitioners shall ensure that protection and safety is optimized for each medical exposure. And next is also requirement 34, the responsibilities of the government specific to medical exposure. The government shall ensure that relevant parties are authorized to assume their roles and responsibilities, and that diagnostic reference levels, those constraints and criteria and guidelines for the release of patients are established. The goal or aim of optimization can be divided into two. In diagnostic and interventional medical exposure, is we want to keep the exposure of patients to the minimum necessary to achieve the required diagnostic or interventional objective. In therapeutic medical exposure, we must ensure the exposure of normal tissues as low as reasonably achievable, consistent with delivering the required dose to the planning target volume. So now, why the optimization applied to a medical exposure requires a special approach? It is because too low a radiation dose could be as bad as too high a radiation dose. For example, diagnosis and treatment. In diagnosis, if we use the low radiation, the image taken are not of suitable diagnostic quality. But in treatment, the cancer is not cured. So, we will keep repeating to apply the radiation on patient, so that will increase the radiation dose on patient, and it will give effect toward the patients. Tools used in optimization of protection and safety include DRLs. DRL is service of on dose unusually high or low. Dose constraints, typically patient dose and national DRLs. Design consideration, basically design consideration, calibration of equipment and programs of quality assurance is for the equipment and conform to applicable standards. Operational consideration is the patient condition. For example, maybe the patient is pregnant or breastfeeding or pediatric. Patient dosimetry is diagnostic radiology and image guided interventional procedures is performed. This is the example of diagnostic reference levels. Now, we talk about the radiation protection after the treatment. Requirement for the release of patient after radionuclide therapy. So, registrant and licensees shall ensure that there are arrangements in place to ensure appropriate radiation protection for members of the public and for family members before a patient is released following radionuclide therapy. What is meant by the arrangement in place is such as control room or protected area where patient is quarantined before release to wait for the radiation become low. And now we talk about the physicist's role. Physicists must know the activity of radionuclides in the patient is such that doses that could be received by members of the public and family members are acceptable and compatible to the relevant dose constraints. Second is the patient or legal guardian of the patient must be provided with written instruction for keeping doses to persons in contact with or in the vicinity of the patient ALARA and for minimizing any spread of contamination. Second, the information on the radiation risk. And third, it is possible that patient treated with gamma emitted radionuclides could trigger security alarm, for example at airports and border crossing, particularly in the period immediately following discharge from hospital. That's all. Thank you.
Assalamualaikum warahmatullahi wabarakatuh. My name is Aina Nabilah binti Abdul Rahman, and today I'll be continuing presenting the use of radioactive substances for treatment and pain palliation in the subtopic of risk management of radioactive substances. Before we go further, we should know what is risk management. Radioactive material have been found to be very effective and it is used in variety of medical applications, for example in diagnostic, therapeutic and research purposes. Due to this, it produces a wide range of radioactive waves. The waste that is generated during the different applications of radioisotope in medical or biological research is considered as biomedical radioactive waste. The overall goal of biomedical radioactive waste management is actually to minimize the hazard posed by the waste prior to discharge or disposal, which included consideration of the radioactive, biological, chemical, and physical hazard associated with the waste. Radioactive waste can be divided by 5 types, which is liquid waste, gaseous waste, solid waste, spent cell sources, and lastly, decommissioning waste. In this slide, we can see the process of management of biomedical radioactive waste, which start with the purchase of isotope, then application of isotope itself, which is it will producing waste, and then waste collection and segregation. Then we can be divided by long-living isotope and short-living isotope, which can be considered to go from pretreatment or for storage for decay. I will be explaining it more in the next slide. In this slide, I will be explaining waste prevention and minimization, which is meaning of waste prevention is an essential precursor of any radioactive waste management strategy, why waste minimization is fundamental to any radioactive waste management strategy. It is because when we design an experiment or planning patient diagnosis, it need to use radionuclide and should always be justified, and only the required quantity should be procured. Because the objective of waste minimization is to reduce the activity and the volume of waste for storage, treatment, and disposal. For example, minimizing the activity of the waste by using short-lived radionuclide whenever possible, which can be decayed prior to disposal itself. Next is collection and segregation waste. This is to minimize waste arising and optimize use of available radioactive waste disposal route. Waste should be accumulated and segregated with due regard to the future step used in the waste management process. Basically, collection of waste should be made in containers suitable for the waste itself, which having due regard to its physical, chemical, biological, and radioactive properties. Segregation of waste at the point of generation is an essential component of the waste management process because it is required in order to minimize waste hazard and to facilitate subsequent processing of waste. The segregation of waste at the point of origin is actually more efficient than performing segregation after mixing. The slide now is packaging and labeling. So basically, when we have radioactive waste, we should package it well and label it so other people also know that is for example, strontium waste. So basically, appropriate packaging and correct uses of such packaging is essential component of the waste management system for biomedical radioactive waste. Choice of the proper type of material and package style is necessary to minimize waste volume, provide reliable containment during storage, facilitate handling, and simplify subsequent treatment. In this slide, we'll be taking a look at consideration for storage of waste, which is on-site interim storage of biomedical radioactive waste may be necessary for different reasons, with storage for decay, storage before treatment or treatment, storage prior to returning to vendor. It is important because some have long-lived isotope and some have short-term, short-lived radioisotope, which we need to consider some to decay first and so on. And although the safety requirement in the case of temporary storage may be less stringent than for lateral storage, nevertheless, adequate attention should be paid to the need of shielding and prevention of leakage. Basically, each facility should define a policy according to government and guidance regulation. In this slide, we can see the summary of the process of control of purchase of radionuclide until the disposal or release and many more. So basically, this is from waste from addiction of radionuclide. Some of it will be returned to the supplier on the spot, and some need to be collected and segregation, categorization, measurement and packaging, then undergo pre-treatment, dispensation, on-site treatment, decay storage, and then transportation for treatment, conditioning, or even release at clearance or maybe on-site treatment mainly by incineration and conditioning, then we disposal or release it. I think that's all from me and from my group. Thank you. And in conclusion, we should know radioactive material have many benefits to us, but we need to take into consideration the protocol procedure, patient dose and dose administration, also monitoring the safety for the surrounding, even to personnel and to the people among us itself. And we should need to take account to a good waste management to avoid any contamination.